Okay guys, so today we're going to continue our discussion of antivirals. We had a really short lecture previously on antivirals, but we did cover the antivirals that we use for influenza, to prevent influenza or to very modestly shorten the course of influenza A and influenza B. We talked about antiviral use for the treatment of RSV. And then we had just gotten started talking about hepatitis and all the different types of hepatitis. We talked about hepatitis B, and we left off here talking about hepatitis C. So we'll continue starting with hepatitis C, and then we'll go through herpes virus as well as HIV. Hepatitis C preferred treatment is a combination of drugs that we call direct-acting antivirals. So there are numerous different types of DAAs or direct-acting antivirals, and we choose a combination of different drugs. Now we want to pick different drugs that target a different part of the HCV life cycle. So what I mean is you don't want to choose, two drugs that are the exact same mechanism and do the exact same thing. You want to take two drugs or three drugs that are attacking the hepatitis C at different parts, at different angles, and that ends up giving you the best outcome or the best efficacy. Now, when we looked at interferon, we saw that interferon was acceptable or was active in hepatitis C, and we used to use it a lot for hepatitis C. But now that we have these direct-acting antivirals, they're much more effective. So PEG interferon is not recommended for hepatitis C anymore because we've just got these other drugs that work so much better. So over here you see some combinations of drugs that are used for hepatitis C. You see that there's numerous different combinations and that they're typically available as one single pill. So like this combination of drugs here is available as just this one single brand name drug because they are always used in combination. You'll notice that which combination we choose depends on the genotype of the hepatitis C. So treatment is very closely related to the specific genotype of the virus. Here we see the protease inhibitors that are effective in hepatitis C. At the bottom, you see the drugs are listed: Paritaprevir, Grazoprevir, Voxilaprevir, Glycaprevir. You'll notice they all end in Previr. So protease inhibitors, Previr. They inhibit protease. They inhibit the specific serine protease that's necessary for converting this single large polyprotein that's encoded by the hepatitis C virus into individually active proteins. So typically there's a serine protease, an enzyme that takes this large polyprotein and splices it and separates it into individual proteins and enzymes that are necessary for the virus to replicate. Without these active proteins, the virus can't replicate and the life cycle is disrupted, right? It's got to be able to replicate to spread. So if you stop the splicing of this one large protein into smaller active proteins, you stop the process. When we look at protease inhibitors, something to keep in mind is that there are very significant drug interactions. They are metabolized, very highly metabolized by CYP3A4. So any inhibitor or inducer of CYP3A4 is going to affect the concentration of these protease inhibitors. In order to be effective, the Paritaprevir requires boosting, kinetic boosting by ritonavir. We'll talk about ritonavir a lot with antivirals. Specifically, when we talk about HIV treatment, we'll talk a lot about boosting and this idea of boosting. Ritonavir was initially an actual antiviral medication, but it's not very effective in that way. What we found, though, is that ritonavir is a very, very strong CYP3A4 inhibitor. So if you give ritonavir with a drug that's metabolized by CYP3A4, you're going to stop the metabolism of the drug, right? And you get much higher drug concentrations. So we do that intentionally, and that allows us to lengthen the dosing interval. So we don't have to give the drug as frequently if it's not being metabolized as much. It allows us to get to higher concentrations that are more effective. It's actually beneficial to boost the first drug by giving ritonavir to inhibit its metabolism. So paritaprevir is always given with ritonavir, so it shouldn't be given alone. Adverse drug effects of these protease inhibitors include rash, hives, nausea, fatigue, and anemia. A lot of them cause rash. So when that big polyprotein gets spliced or broken up into smaller active proteins, one of the individual proteins that gets liberated is this NS5B polymerase. And this is the only polymerase that Hep C uses for viral replication. So it's super important. It's absolutely necessary for viral replication. Now we have two different types of drugs or classes of drugs that can inhibit this polymerase. So different types of these polymerase inhibitors. We have nucleoside or nucleotide analogs and then non-nucleoside analogs. The nucleotide analogs bind to the polymerase at the normal binding site. So they're analogs of like the normal nucleoside or the normal nucleotide that would bind there. So they bind at the normal binding site and then they block it, right? They block that binding site. And then that inhibits this polymerase. It can't work any longer for viral replication because the drug is blocking that binding site. This nucleoside or nucleotide analog is Sofosbuvir, and then the non-nucleoside analog is Disabuvir. And what we mean by non-nucleoside analog is that the drug doesn't bind at the normal binding site, right? It's not like supposed to replicate or look just like a nucleotide. It looks different and it binds at an allosteric site. So it binds at a different binding site. But when it binds, it changes the shape of the polymerase and then the binding site's messed up and the binding site doesn't work anymore and the polymerase doesn't work anymore. So the difference between these is just where they bind on the polymerase. But regardless of where they're binding, they both inhibit the polymerase. And then that inhibits viral replication at another step in the process than we saw with the protease inhibitors. Again, these are just the same, this is the same list that I showed you guys before. These are just different combinations of drugs that we use for hepatitis C treatment. And you can see these polymerase inhibitors included in some of these combinations, right? Disabuvir, you see here, Sofosbuvir, Sofosbuvir. So they're used pretty commonly. In most of these treatment combinations for Hep C, we see a polymerase inhibitor included. And one of the reasons for that is that they're really well tolerated. A lot of the other drugs have side effects and drug interactions and all these problems. These are really well tolerated. So adding them onto therapy gives us efficacy without giving us a bunch of extra problems. Okay, so the next class are the NS5A replication complex inhibitors. Remember, we said that Hep C has this big polyprotein, right? That's what it's coded for, this big protein. And then that has to get spliced into separate proteins that are active. We just saw NS5B, that was the polymerase enzyme. NS5A is another one of those proteins. It's a protein complex that's necessary for viral replication to occur. So this is just another target that we can hit with the hepatitis C to stop viral replication. So again, they inhibit this viral protein, NS5A, and that inhibits hepatitis C replication. You see examples of the drugs down here at the bottom: Ledipasvir, Ambitacvir, Elbasvir, right? You notice all of them end in asvir. Okay, the names all kind of go together with all of these. So if you memorize the endings, you can always kind of pick it out. So asvir are these replication complex inhibitors. When we look at these, something really important to keep in mind is that they have a lot of clinically significant drug interactions. They're metabolized by CYP enzymes, and they're not all the same. So like different drugs are metabolized by different CYP enzymes, but they are highly metabolized by CYP enzymes. So they might be contraindicated with CYP inducers. You just have to check with the individual drug to see which CYP enzymes and which inducers they're contraindicated with. But if you give it with a drug that induces the CYP enzymes, then the drug's going to get metabolized very quickly, and then you're going to have treatment failure. So it's just important to keep in mind, you don't have to memorize every possible interaction because that would be a huge list. Just keep in mind that they are highly metabolized by CYP enzymes, so there are clinically significant drug interactions that could lead to treatment failure. These drugs themselves inhibit P-glycoprotein, so that's another opportunity for them to interact with other drugs. Ledipasvir, I'm like adding letters in here. Ledipasvir requires a acidic gastric pH for absorption. So that means you don't want to be giving it with anything that that increases the pH of the stomach. So if possible, patients who are going to take this need to stop any PPIs, any proton pump inhibitors that they're taking. So that would be like omeprazole, pantoprazole, any PPIs need to be stopped. And then also, of course, they shouldn't take it with like an antacid or anything like that. That would increase the pH of the stomach. Ribavirin is another drug that's approved for use in hepatitis C. It's approved for use in combination with other agents, either with interferon or with the DAAs, the direct-acting antivirals. Now remember, I said that interferon is not preferred any longer. The direct-acting antivirals are so much more effective that you're really not going to be giving ribavirin plus interferon. What you're going to be giving is ribavirin plus a combination of DAAs. Which we just talked about the different types of DAAs. The mechanism for why ribavirin is helpful in hepatitis C is unknown, but there's a lot of clinical evidence that shows that it's effective. We don't know how or why, but we know that it is. It's not a guess, like it is proven, shown. We see that there's improved viral clearance and decreased relapse rates. The choice of whether or not it's going to be added just depends on specific case factors. So as you work your way through the guidelines and looking at your specific patient, you'll have to decide whether or not it's appropriate to add in this specific patient. But examples of things that you'll look at include the subtype of Hep C, mutation status, cirrhosis status, so the status of the patient's liver, as well as treatment history. What have you tried? What has worked? What hasn't worked, etc. Dosing with ribavirin is weight-based, so that's something to keep in mind. There's not a standard dosing profile. It is a weight-based dosing schedule, and it is twice daily dosing. So compliance is a little bit harder than with the once daily drugs. Also, it needs to be taken with food. So twice a day with food both times makes compliance a little bit harder, but absolutely necessary. So we're done with the hepatitis viruses. Now we're going to move on to herpes virus and talk about how we treat the herpes viruses. Now, there are multiple different herpes viruses, and they can cause disease in various parts of the body. Can result in things like cold sores, the oral mucosa, viral encephalitis, genital infections are common. So we do see various different types of infection in various parts of the body. When we talk about using antivirals for herpes virus, antivirals are only effective in the acute phase of infection. So when there's actually active viral replication occurring, right? When there's, like people say, a breakout and there's visible signs of infection because the virus is replicating over and over, that's when antivirals are effective, right? They have no use during the latent phase of infection when the virus is just present, but it's not replicating. Okay, so only used during the acute phase. Acyclovir is kind of like the prototype antiviral that we use in herpes virus. It's like the first major one that we use. Acyclovir is effective against HSV, herpes simplex virus, type 1 and 2. It's effective against varicella zoster and some Epstein-Barr mediated infections. Acyclovir is the drug of choice for HSV encephalitis, and we very commonly use it for genital herpes infections, again, during the acute phase. It's an old drug and it's relatively cheap, much cheaper than some of the newer agents. It can be prescribed prophylactically for seropositive patients pre-bone marrow transplant to try and prevent infections from occurring, and post-heart transplant. Acyclovir is a guanosine analog, so it's like guanosine. However, it's not guanosine. So it acts as a substrate for viral DNA polymerase, and it gets incorporated into the viral DNA. The DNA polymerase, when it thinks that it's adding guanosine, it's going to add acyclovir instead. And since acyclovir has components that are not present in guanosine and shouldn't be there, it's not right. So you're incorporating the wrong thing into the viral DNA. Resistance is possible with acyclovir. The resistance that we see, though, is typically in immunocompromised patients. So, HIV patients, or patients who are, the immune system is suppressed, either due to, our suppressing it in, pre-bone marrow transplant, or post-organ transplant, or to treat autoimmune diseases, etc. Also, there is cross-resistance. So if somebody has a herpes virus that's resistant to acyclovir, it can be resistant to other agents in this family as well. Acyclovir is available via IV and oral routes. It's also available topically, but it doesn't have proven efficacy when used topically. So I do not recommend topical acyclovir. It does distribute well into body fluids, including the CSF, which is why it's recommended in HSV encephalitis. It is cleared by the kidneys, so acyclovir does accumulate in patients with renal failure, so we do have dosage adjustments that are necessary when there's kidney dysfunction present. Now, acyclovir is like the original form. Now, there is another drug that's very similar called valacyclovir. And the valacyclovir form has much better bioavailability when taken orally. So the oral, so PO valacyclovir equals the same plasma concentration as IV acyclovir. So it's got better oral availability. It is newer, and it used to be much more expensive, like very expensive. The price has probably come down since I was in a pharmacy, but it is still a bit more expensive, I'm sure, than the Acyclovir is. But it's got a better bioavailability, and that allows you to extend dosing intervals, which is easier use. Adverse drug effects include nausea, vomiting, diarrhea, and headache for the oral formulation. The IV formulation has been associated with transient renal dysfunction at high doses or in dehydrated patients. So that means make sure that your patient's not dehydrated, right? Make sure that you've got plenty of fluids running if you're going to be giving the IV formulation, and make sure your doses are appropriate, as well as keeping an eye on renal function. Sujathavir is a cytosine analog. So it's just cytosine instead of guanine, but it's still an analog of one of the bases that are used in the formation of DNA. Right, so the cytosine analog, the Sujathavir, gets incorporated into the viral DNA instead of actual cytosine. So you've got the wrong thing incorporated into the DNA, and that inhibits DNA synthesis, and it inhibits the actual viral replication that occurs. We use Sujathavir in cytomegalovirus, or CMV retinitis. CMV is a herpes virus. So CMV retinitis in patients with AIDS, which this is common in patients with AIDS. So Sujathavir is used in this situation, very select subset of patients. When we look at the kinetics, it is administered intravenously, so it does have to be given IV. However, it's given at prolonged intervals. So typically it's given once weekly. Now this eliminates the need for permanent venous access. We'll see another drug coming up, Ganciclovir, and that's also given IV, but you have to give it on a regular basis. So you do need actual permanent venous access. You don't need it with Sujathavir. You can just inject it IV once a week, and that's fine. We don't have to have access open. Sujathavir is renally toxic. It has nephrotoxicity, so we give it with oral probenecid and IV normal saline to try and decrease that nephrotoxicity. The IV normal saline, obviously hydration is typically beneficial in a drug that's nephrotoxic because it decreases the concentration of the drug in the kidneys. Probenecid is a gout drug. It inhibits an anion transporter in the renal tubule. So we typically use it for gout, but in this case, it decreases the amount of Sujathavir that enters into the tubular cells. So think about like in the kidney. If this is the nephron tubule, right? So all the stuff that's going to go into the urine is going through this tubule, and it's lined with cells. These are the tubular cells. Well, the tubular cells have little pumps on them, right? And this little pump right here takes the Sujathavir and it pumps it into the cell. And then it's going to go from the cell in here and it's going to get excreted. So the thing about Sujathavir is it stays intracellularly for a long time. Once it enters into the cell, it stays in there for a while. That's why we can give it at prolonged intervals. So much of the drug enters into cells and it takes a while before it leaves the cell. So it's effective for a really long time because it's not going to get cleared when it's in the cell, when it's intracellularly. But if you think about that, we now have all of this drug that's also being pumped into these tubular cells. And when the Sujathavir is in the tubular cells, it damages them. That's how it's nephrotoxic. So if we inhibit that, then we help to inhibit the nephrotoxicity. So that's what the probenecid does. The drug still, some of it gets cleared by glomerular filtration, and that's fine. It's just we don't want the drug hanging out in these tubular cells. So that's what we do with the probenecid. That's why the probenecid is important. It inhibits that transporter. Again, it can be associated with renal toxicity. So it's contraindicated in patients with moderate to severe renal dysfunction. It's also contraindicated with other nephrotoxic drugs. Other adverse drug effects of Sujathavir include neutropenia and metabolic acidosis. Ganciclovir I just mentioned because it's the one that has to maintain access, venous access, because it's got to be given regularly. But Ganciclovir is an analog of acyclovir, so it's structurally similar to acyclovir, but it has much greater activity against CMV. So that's specifically where we use Ganciclovir is in CMV. We use it for CMV retinitis in immunocompromised patients. So like Sujathavir, right? Sujathavir is also used in CMV retinitis. But we use it not just for treatment, we can also use Ganciclovir for prophylaxis of CMV in transplant patients who are obviously immunocompromised or immunosuppressed. Ganciclovir is a nucleotide analog, so it appears to be a nucleotide, but it's not correct, right? There are structural differences. So it inhibits the viral DNA polymerase. Ganciclovir can actually be incorporated into the viral DNA as well. So it gets incorporated into the viral DNA, and then because it's not the correct actual nucleotide, it's not the correct structure, chain termination occurs. So you stop the elongation of the DNA. Ganciclovir is given via IV administration. And again, the Sujathavir can be given once a week, but the Ganciclovir is given at regular intervals, regular dosing intervals. So you need to think about how you're going to maintain IV access. This might not be an issue, or it might be an issue. If you're treating CMV retinitis in a patient with AIDS, and the reason they have AIDS is from IV drug use, then you might not want to have open IV access, and you might want to give the weekly Sujathavir instead. So it's something to keep in mind. It is, again, cleared renally, so the drug can accumulate in patients with renal failure. Adverse drug effects include a severe dose-dependent neutropenia. So it is important to do regular blood counts. And then it is carcinogenic and teratogenic. There's actually a black box warning regarding use in pregnancy. So it should not be given to pregnant patients, patients who might become pregnant. Now, Ganciclovir is like the original. This has to be given IV, but there is another formulation, Val Ganciclovir. And Val Ganciclovir is just the Val ester. It's just another formulation. We've added a few functional groups to the Ganciclovir. But adding those structural functional groups, changing the Ganciclovir to Val Ganciclovir, improves its bioavailability. So now this formulation can be given orally. Okay, so Ganciclovir is IV only, Val Ganciclovir is oral. So that also kind of takes care of that IV access problem. Okay, so moving on to Penziclovir and Famciclovir. They're really closely related to each other because Famciclovir is the prodrug of Penziclovir. So, and the difference is like how they're given. Penziclovir, you guys see over here, is topical administration. So you give the active drug right away and you apply it to the site of action. Famciclovir can be given by mouth. It can be given orally, and then it gets activated into the active Penziclovir in the body. So Famciclovir is oral, Penziclovir is topical. The mechanism of action is to inhibit HSV DNA polymerase, and it's active against HSV 1 and 2, as well as varicella zoster virus. Penziclovir and Famciclovir are used for acute herpes zoster, for genital HSV, as well as recurrent herpes labialis. Kinetics, the Penziclovir, because it's applied topically, it has very negligible systemic absorption, and so there's not a large kinetic profile there. And also because of that, it's not associated with vast adverse drug effects. It's really, really well tolerated. The Famciclovir, which is the oral medication, is associated with headache and nausea, but otherwise relatively well tolerated.